Next, we have Mat Southwell from COACT, who's going to talk about support for people who use stimulants.
Cool. Thank you very much. I'm very happy to be here today to speak about stimulants. Thank you, Liam, for organising this exciting session and sending greetings to Monica Cappeggio, who's been a key part of this development work with you and ODC. But with the current Trump destruction of the UN, we're absent some key colleagues. So, I'm very happy to have just literally received the first hot off the press news stimulant technical guide. And this is a guide produced, funded through the UNITAID project. It's part of a Frontline AIDS COAC resource supported by London School of Hygiene and Tropical Medicine, Densuluk Nuru from Kyrgyzstan, the National Institute for Health and Care and Research, Charisma from Indonesia, and the SIP study from the UK. And while they're not on this printed version, the next version will also include the Elton John AIDS Foundation, who funded the Kyrgyzstan project. So stimulant pipes have been discussed, and I'm going to talk about stimulant pipes on the way into talking about the treatment response, because I think treatment always starts with harm reduction. So let's talk first. So in this case study, we set out the case for stimulant pipes. There is clear value of stimulant pipes, which the WHO support as an engagement tool. There is also clear, sorry, I should be going back to the last slide. There is clear value in the pipes also as a route transition intervention. We saw this clearly in the SIP study. There's a significant number of people who had previously injected stimulants who are choosing to use pipes as a way of reducing their harm. So while pipes may lead people into higher dose using, which brings greater risks, for those people moving from injecting, that can be a reduction of risk. So again, understanding that within this pattern, pipes play a key route transition role because they give a very similar surging effect that is also provided by injecting without the much more bloodborne virus risks or without as extensive bloodborne virus risks that go with it. The WHO and I continue to argue over whether there is clearly a prevention effect of these pipes. I think the SIP study shows clearly that there is prevention of low-level viruses. We see people getting cold and flu viruses within groups. We see cold sores quickly going around smoking groups. Hep C has been found on stimulant pipes, and we know that dehydration and hot pipes all cause bloodied lips. For me, that makes it a Hep C prevention tool. I think that's good enough for me to see there's a clear risk. I understand for scientists, people need to prove it, but that for me seems like a low-level repeated risk. And then alongside that, as Gunnar just said, we've got all the sexual risks, which then provide, these pipes also provide a pathway into engaging people. And then potentially that provides a whole series of onward support into HIV testing, Hep C testing. And as Mark Kinsley, the founder of the first person to ever give out stimulant pipes in New York, he said, no, look, Matt, they just really gave us a place for people to be noticed, for people to then come in, and then we could do all the other things we know how to do, from substance misuse to harm management work to harm reduction to all those other things. But if you don't have that front-end engagement tool, you don't have a reason to connect with people. And this is the very clear evidence of the SIP study from the UK, acknowledging Lucy Platt in the room, who's also part of this study, led by the wonderful Professor Magdalena Harris. So you can see that we actually started with a real beast of a pipe. We had a slight mistake over dinner with Andrew, Magdalena and I, positing about what size of pipe we had, and then Andrew went out and made them before we then changed our mind and went, no, maybe that long pipe wouldn't work. And then by which time Andrew pointed out he'd already just made 10,000 of them. So we went into the study with a pipe that was maybe not the ideal pipe. And when you take a pipe to crack users that's not right, they tell you repeatedly that it's not right. And no, that taught us lessons. In hindsight, having done the UNITAID project, we would do values and preferences at the start. We did it as we went along, and that's why we end up with a Goldilocks of crack pipes on the bottom here, which whenever I showed all the South African drug users early in the week, all of these versions, they were immediately going, no, no. And then as soon as we get the SIP pipes out, everybody goes, yeah, that's the one. So we now have the Goldilocks of pipes, the SIP pipe, which is a wonderful shorter stem, Also, if you see these gauzes, these allow people to move away from using scrubber. Really concerning x-rays of people with crack with lots of metal pieces in their lungs. So this is really a way of allowing the crack to run through the gauze or the foil stuff, but it doesn't then come detached and fall into your lungs. So real improvements. We also talk about the case as the case for control, because having this nice flat case allows you to break your rocks up, to plan your sessions out, and it helps you then think about self-control alongside harm reduction. My God, look at the time. Right, and then just here is Magdalena Harris, and I think that one of the key things that came out of this study is, one, isn't it fantastic to have an open drug user as a professor leading a study? And secondly, what that does to the study by having drug users keenly involved all the way through, myself as a community PI, but also Nick Booth working alongside me. This is Magdalena interviewing Nick about his history of being a crack user from when he was 16, key to breaking into the community. Every single plan we had around the peer sites went wrong, and we lost all the drug user groups, peers became ill. So the peer team had to start again, and we had real creativity of keeping going. And I think that's what peer work's about. We know how to secure privileged access into our communities. So wonderful STIP study, that's the first of our case studies. The second two case studies we have are from two lower middle income countries. So first, Kyrgyzstan. Big kudos to Alexei Lahov, who has been leading this project with the Den Solok Nuru, funded by Elton John AIDS Foundation, both sponsors of our report. They're giving out this huge kit using online outreach to reach people, so going through dating apps, going through drug selling environments, going through different social media forums. Very clever use of bots on Telegram channels that automatically respond to people, DMs, group chats. That's how they draw people in, and the pipe kits become the engagement tool. Come and talk to us, we'll give you this kit. In the kit is also an HIV self-testing kit, which then allows people to test and then send their test back. But what the key thing that Alexei highlighted was the peer workers were critical. Now, they were the ones who understood how to break through the social media connections. They were the ones who understood how to engage people. Indonesia, very similar model. No, not similar model, but another model of giving out pipes. Amazing outreach going on in Jakarta. They have this fantastic slogan, which is eat, sleep, drink, repeat. And I think there's a really clear set of harm reduction messages. These are all different stimulant drugs. Indonesia is methamphetamine, Kyrgyzstan is cathinones, and then SIP is crack. But it really shows that we have some core principles of how to work with stimulant use. In terms of empowering people to change, I'm going to make some very quick comments, don't worry. The Crack Squad is an example that I was involved in from the UK. Community empowerment is the way we teach people to have self-control. Don't wait for people to lose control. Support people to be in control through drug user groups. Sean Shelley's wonderful contemplation group run here in South Africa, designed as a motivational and mindfulness-based group with strong peer principles. I'm really trying to champion it around the world, so anybody wants to learn more, come and talk to me or Sean. I'm not going to steal from Liam's work, but no, look, we've got some treatment options. I don't agree with the UN that we don't have treatment options. I'm sick of people saying we've got to wait until there's research. Do the bloody work and research it. We shouldn't be waiting all the time for research before we do work that self-evidently works. We've been seeing stimulant prescribing working since the 1960s. When are we going to start backing it properly? We've got US government guidelines backing it, yet the WHO backs off. This is not a time for caution. We need to get on and support people who use stimulants to make meaningful change. And that means a wide range of stimulant agonists. And I'm also really excited to hear Liam's use or studies around novel stimulant options. And let's not forget, many people use cannabis as a drug to regulate their stimulant use, to come down off their stimulant use, or as a supportive tool to manage ADHD and other neurodiversity, which is often a reason why many of us are using stimulants. Well, not the only reason why we're using stimulants, but it's a factor in why we're using stimulants. And let's not forget the wonderful tools we've developed as the Crack Squad. So the Crack Squad worked with the Royal College of General Practice, developed the eight-point crack health check, which basically got GPs to stop worrying about people being crack users and to remember that we had lungs and hearts and brains and sexual needs and things that they could engage with us, which then liberated the GPs to work with us rather than focusing on us as these demonic crack users that you couldn't engage. And on from that, we've now developed 4 more of these stimulant health checks for ketamine, crack, methamphetamine, and catenones. And these are all available on an open source basis. Thank you. And there's copies of the reports at the front.